Well, I think our journey in racial and economic disparities started back even in the mid-'80s. Minnesota was a community that welcomed refugees. And in fact, when I started training, we had a clinic, still exists, for the Center for International Health. That was a clinic for new immigrants that came to the Twin Cities. And as our community has become more diverse, we know that our patients aren't just at one clinic. Our diverse communities are throughout the Twin Cities area. In 2001, Crossing the Quality Chasm was published, and then 2002, Unequal Treatment was published. And so we knew that there were disparities, and in our commitment to improve care for all, we need to improve care for all populations, the diverse populations we serve. And so that was the background in which we got started on this work. In 2002, after the Unequal Treatment was published, we also were part of actually IHI's Pursuing Perfection grant in the mid-2000s, and one of the things that we wanted to do was to take a step back and say, if we were going to provide care, how do we provide all recommended care to all patients at every visit, and really spent time looking at our workflows to identify all the different patients that we served. And about that time, we also went up on an electronic health record, which gave us the capabilities to ask our patients their preferred language, their self-identified race, and our communities told us it's very important to have country of origin recorded. And that way we could ask our patients to record in our electronic health record, so we only had to ask once. And then after about 2 years of collecting the data, we were able to start looking at our quality metrics by different cohorts and different segments. And we started where we knew there were national disparities. That's where we started looking at them in our own organization. We also did an organizational assessment back in 2003 to ask our clinicians and staff if they thought disparities existed. And as you can imagine, they said, yes, disparities exist, not in our organization. So for us to have our own data was really important, because as we could look at our own data, then we knew which communities we needed to outreach to in order for them to help us improve the care. In Minnesota and in other communities across the United States, our communities are becoming more diverse. And so even in Minnesota, 3 out of every 4 new people that come into the state to live are from communities of color. So if we want to provide health care for all in our state, we need to make sure that we're providing health care for all communities, and we know that there are disparities in care. And so for us to be able to recognize them in our own care system and then be able to provide all patients the opportunity to improve the health to the best that they can, I think is our obligation, and that's why we've been really passionate around this work.